Hello, and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I'm your host, Rebecca Sapp. I'm a board-certified allergist and immunologist and a fellowship director who always enjoys learning more about the exciting field of allergy and immunology. Our podcast series will use interviews with thought leaders from the world of allergy and immunology to keep you up to date on new developments and to review core topics. Today's edition of our Conversations from the World of Allergy podcast series will focus on the topic of oral food challenges, as well as early introduction of foods. We hope this discussion will be helpful for patients with food allergies, as well as their families, in addition to physicians taking care of food allergy patients, which is really all of us given the prevalence of food allergies. We are pleased to welcome Kim Mudd, who is a nurse at the Johns Hopkins Division of Pediatric Allergy and Immunology. She is also the nurse manager of their food allergy research team. She has a long history in food allergy research, education, and community advocacy, and has multiple publications in the field. She has also been involved in the Quad AI and has served as the chair of the Allied Health Professional Assembly. She currently serves as a member of the Adverse Reactions to Food Committee, as well as the Allied Health Representative to the Office of Medical Education Committee. Kim, thank you so much for taking the time to join us today.
Thank you. Good morning.
Morning. I'd like to start by getting to know you a little better. Can you tell us just a little bit about yourself and include something you like to do outside of the clinic?
So I have been involved in the world of allergy since before most of your people were born. I started as a research tech in a research lab in the 80s and ended up kind of falling in with this incredible group of people who were doing a lot of work in asthma and allergy, and I ran the lab and met all these wonderful, wonderful people. Subsequent to that, it was very clear that I needed a lot more interaction with people and less interaction with mice. I went to nursing school and then finished my master's degree and just have been able to stay involved with this unbelievable group of people. And I kind of started in food allergy at the beginning of my career and never left. So now my official title is the Queen of Food Allergy.
Quite a title.
Yes, quite the title. It's earned. But
yeah.
And outside of work, we like to go outside and play. And we our happy place is up in the northern part of Michigan, up in the Upper Peninsula of Michigan. We have friends that live up there, and we like to kayak and hike. We have now 3 granddaughters. Trying to get them introduced to go outside and play as well. So it's that's what I like to do. I also decided somewhere in this process that I needed a puppy. So now I have he's about 18 months old now. So but he's a boy and he's still a puppy. So there's a fair amount of taking him outside locally, get outside and play, and I enjoy that.
Absolutely. I had a chance to canoe in the Boundary Waters in Minnesota, and really developed a love for being on the water. It's really beautiful out there.
It is magnificent. There are mosquitoes up there that can literally carry off a small child, but the Boundary Waters, that canoeing and kayaking up there it is magnificent. It truly is beautiful.
The mosquitoes are worth it, but I agree that they can be quite ferocious. So you've helped kids of all different ages negotiate life with food allergies. I was wondering if you could tell us some of the biggest challenges at different ages. So starting with families with infants, what kind of challenges have you seen them really face?
So the little teeny weenies, that initial diagnosis is horribly alarming to the family. So either there's been an event which has scared everybody, and now you've gone through and you've done skin testing, and yes, your child has an allergy to milk or to egg or to peanut, and here's an EpiPen, and here's a lot of information, and it's overwhelming for them. even if they've come to this diagnosis because of, terrible eczema, and somebody does the correct workup and actually realizes that there's a food allergy component to the eczema, and here's what we're going to do about this, and here's how you're going to avoid these foods or not introduce these foods or wait until you introduce these foods. And oh, by the way, here's an epinephrine to use. That is so overwhelming for the families of these. They're little tiny babies. And somebody said, we can help you, but it is very, very overwhelming for the families with that new diagnosis, a new baby, especially if they're dealing with some eczema. Nobody's getting a lot of sleep. It can be a bit much. It can be a bit much.
Yeah, especially with families who have other children as well, and
Oh,
trying to negotiate life with a baby with a food allergy and then with other kids as well in the house.
and we know how kids are, and they want to be helpful, and they want to touch the baby, and they want to poke their fingers on the baby's eye and the nose and everything. And so you're constantly, let me see your hands. What have you been eating? Can I wash your hands? It rearranges the entire life, the entire household. And I understand where that comes from, but it is overwhelming.
Absolutely. Now, what about toddlers? What are particular challenges that face families with food allergies in toddlers?
So the toddlers, I love my little toddlers, but let's be honest, they'll eat anything, right? They rummage around. They're like little vacuum cleaners. So they find something on the floor, first thing it does in their mouth, because that's their primary sensory organ. So that, again, adds to the challenge of trying to maintain some kind of a safe environment with a toddler. In addition, if you hand a toddler something, they're going to put it in their mouth. So even if they're not finding things on the floor, if somebody else, another sibling, another child at daycare, a well-meaning adult, hands them something, it's going in their mouth. So I actually have a family that ended up got a t-shirt that says, "Don't feed me, I'm allergic," which I think is hysterical, but I understand where that comes from. Their primary sensory organ is their mouth. Everything goes in their mouth, and if they find it, it's going in there. And that's alarming especially for a food allergy family.
Absolutely. There was an infamous incident in our family where my son, at the age of 2, was trying to get popcorn kernels out from under the couch. Who knows how long they had been there, and eat them as a little snack. We
Oh,
thought, oh goodness,
that would be a choking hazard.
it would be a choking hazard. And what about elementary age kids? So a little older, a little more savvy.
A little more savvy, and at that point, they're a little bit better at advocating for themselves. But again, they're out of the family's direct supervision. They're in school. They're having to negotiate this by themselves. They have support. School knows, teachers know, school nurses know, but you really are depending on an elementary school child to be able to advocate for themselves. Don't eat that, don't share food. And that whole labeling thing starts happening somewhere, preschool, kindergarten. They start realizing that they're a little bit different than their peers. It's necessary for safety, but it does create more issues, certainly quality of life and the things that we find important. The bullying starts, and it starts so much earlier than we're ready for, and trying to negotiate that when they're young and they don't have a good peer group yet, and they don't have a good sense of self yet, and they're trying to advocate and figure it out, and they're 7.
Yeah.
So that is it can be a very challenging time, and it does produce anxiety, understandably. You're leaving home, and mom's feeling anxious because you're no longer going to be under her direct supervision, and the kids take that with them to school. And it is something that we have to be very aware of, and try to give them some context to deal with that anxiety. A little bit of anxiety is appropriate because that's going to keep them safe. It's very easy to step over that line and be way more anxious than they should be. And then they're not learning. They're not going to be at school learning when they're spending most of the time worrying. So it is something that we need to give them some tools that are age appropriate, and give them an environment where they can actually learn some of the stuff that we need them to learn.
Are there tips or tricks you found that can really help empower kids to be careful with foods, but not to be overly anxious? Because we do want them to develop that independence, and to be cautious, but also not to be so anxious that it really kind of is impacting so many areas of their life.
I like to start this, even at this early age, with some role playing. If someone says this, how are you going to respond? If this were to happen, who are the safe people in your life? How are you going to find somebody to help you, right? And make sure that they understand that we're not expecting them to do this all by themselves. Who are the safe people in your life? Who are you going to go to for support? When are you going to ask for help? And then being very, very attentive to kids that step over that anxiety line. It happens a lot. Of course it does. They don't have tools in their toolbox. So we try to help get them some tools in their toolbox, but in the meantime, being very, very aware of when that anxiety can just become overwhelming.
And then what about our high school kids, those risk takers?
Gotta love them. Gotta love the adolescents. So, the goal of adolescence is to establish another family, another place to be, so that they can leave the nest. That's what they're trying to do. That is the goal of adolescence. Their peers become so very important to them. And indeed, to ask the adolescents, they do want their peers to know about their food allergy. They do want their peers to know about epinephrine. They don't necessarily want them to know about their food allergy and their epinephrine, but they would like for this knowledge to be there. They find that it's a much more supportive environment if their peers are aware. But the peer group is extremely important to adolescents because developmentally that's where they are. The other piece of this is that they're learning self-care all of their life, not just their food allergy, but this is an important piece of it. But we need to give them the opportunity and the environment to practice, right? And I say to some of my families, maybe the first time that they are going to go to a restaurant or some kind of a social event by themselves, establish the absolute house rules that are non-negotiable. You will take your epi with you. I know where you are. You will have a cell phone. Now, the whole food thing, if you don't want me to call ahead and say, I'd rather be safe food, or let's plan some safe food, if you don't want me to do that, then you need to do that. If you're not going to do that, then we need to discuss what you're going to eat while you're at this event and whether or not your plan of not having a plan is going to be adequate, right? If you're going for a quick event, it's a party or something, okay, you may open a soda. If you put it down, you're done. Don't even think about putting your hands in an open bowl of anything. You eat before you leave, you can eat when you get home, but in between, that's it, right? Now, that's clearly completely inappropriate for a weekend outing or something that's going to last several hours, because we know adolescents, they eat all of the time. But we have a plan, and you need to help them formulate that plan and not do it for them every time. Let them take the first piece. Let them take the first step. Let them do a little bit of this, and then you do the rest. I work a lot with families. When you touch the doorknob to go out the door, the keys, cell phone, wallet, epi. And every time you touch that knob, keys, cell phone, wallet, epi. So that it becomes just a pre-programmed thing. Before I walk out the doors, I touch the doorknob, hello, so that you have what you need to keep yourself safe.
It's often nice to establish those habits in high school because eventually they're going to go off to college and you want them to already have that kind of ingrained in them.
Right, exactly. And, and we know, the outcomes the poor outcomes that happen with adolescents, it's because of the delay in epi, right? The delay in epi administration is why we have these bad outcomes. Well, what is that? What causes that? And a big piece of it is not having the epinephrine with them, right? There's more to it. Now that you've got the epinephrine with you, are you able to use it? Do you know what symptoms you're looking for before you use it? Is there somebody with you that can help you? I mean, there's more to it, but having the epi with them is a step in the right direction. And I think that's where we start this process.
You can't use what you don't have, so.
Exactly.
So families often ask, is there anything we can do to prevent our child from developing food allergies, particularly if they already have one child that has a food allergy? What can we do? What do you have some advice for them?
So we have limited options right? This is a huge area of research and a really, really important area of research. This is our ultimate goal. I mean, prevention is where we want to be. We're not there yet. We do know that early introduction is an approach, and we have some good clinical data to support it. It's not perfect, and it clearly doesn't work for everybody, but it is what we have right now. So early introduction is a process that works for most of our families, and it's what we have right now. Other areas, can we manipulate the gut biome? Can we do, can we manipulate mom's diet? Can we do all these things? We don't know the answers to those yet. Those great questions, maybe a good approach. We don't have the data to support it yet.
Maybe describe what you mean by early introduction.
So in children who are developmentally ready to have solids added to their diet, so somewhere between 4 to 6 months, introducing foods such as peanuts, such as milk, such as egg into the diet earlier on than maybe people in the past have done is actually beneficial, especially for somebody who's at risk of developing a food allergy.
And what are those at-risk people?
So the at-risk children are kids that have eczema, all right? And especially when we end up talking about peanut a lot, and in peanut allergy, so if you have a child that's already demonstrated an allergy to something, say eggs, that puts them at higher risk for having a peanut allergy. If you have a little one that has eczema, so moderate to severe eczema, puts them at a higher risk of developing a peanut allergy, and actually any food allergy. If you've got somebody who's got mild to moderate eczema, a little more risk, and then if you have a kid who doesn't have any eczema and doesn't have any known food allergies, not so much with the risk. So it's a spectrum, but certainly we've been able to tease out some things that make us very suspicious for some children that we really want to target early on and get allergenic foods introduced in their diet before those allergies have a chance to take hold. And at the other end of the spectrum are kids that have given us no reason to worry, and we just want to make sure that all foods are introduced into their diet in an age-appropriate way.
And families are often very nervous about introducing these foods so early, worried about their kids having a reaction, and often ask us about testing first. What would you tell them?
So for a child who, again, at the end of the spectrum, when you have somebody that has moderate to severe eczema, that's a child that we're suspicious of, right? That is a child that maybe we do need to do some testing before we introduce the foods at home, especially, again, if you've got somebody with moderate to severe eczema who's already, say, had some egg and has had some symptoms with egg. That's a child that needs to be tested before we introduce peanuts and go on, through the rest of the allergenic foods. At the other end of that spectrum are kids that, no eczema, no indication of any food allergy, and those kids can introduce these foods at home, and they're at no higher risk, right? And should introduce these foods in an age-appropriate manner. That whole in the middle, especially if you've got an allergic SIB, I understand where the family's anxiety comes from, right? They have good reason to ask these questions, but we don't have availability of the options to test all of those kids in that middle who the families are concerned because they've got an allergic SIB, but the child hasn't shown any eczema. It hasn't shown any, pre-existing allergy to any other thing that we're worried about, say peanut. And those kids actually, per the NELBI, and listen to me, per the National Institute of Allergy and Infectious Disease guidelines, they don't need to be tested before those foods are added at home.
Yeah. I mean, I think that we run into the trouble with the appointments take a while to get. And so you actually miss the window. And we know that these little guys actually tend not to have big reactions.
Correct. So we do think that there's a window of opportunity. And indeed, you're completely right. The appointments to get testing, everybody's calendars they're jammed. And you don't want to miss that opportunity, that window open to get these foods into the diet, because we do know that early introduction has a dramatic impact on the development of food allergy.
And how would you coach someone through early introduction? So we'll say they're not in the highest risk group. Maybe they're in the kind of more of the medium risk. They have mild eczema. Maybe they have a child in the family with food allergies. How would you coach them through what food should they start with and kind of what are some of the logistics that can make it easier for families?
So finding a food that A is important to the family, B is something that is there's a form of it available that's appropriate for a 6-month-old infant, right? So powdered peanut flour is very easy to mix with purees or breast milk or formula and get to a form that the kids can manage. You can thin out nut butters with warm water or breast milk and get them into a consistency that's appropriate for a 6-month-old. Clearly, we don't want anybody eating, nut butters or nuts or even, pieces of egg that are too big. They'll choke, right? We do have to worry about choking hazards. So finding a food that's A, important to the family, B, in a format that we can get to it's appropriate for the developmental stage of the infant. And then when you start this process, our ultimate goal is going to be, 2 grams 3 times a week, but we're going to start with just a small amount. You're going to start with one food at a time. You can start with just a very small amount with a feed, observe, wait till the next day, do a little bit more. So we can introduce slowly over time, do one food at a time. So if there are any symptoms, it's clear what foods are related to those symptoms, so you don't confuse the whole issue. And get the food integrated into the diet. Make sure that the child is enjoying it and that you can get that food in, and then go on to a next food. And again, start slowly and build on success.
That's perfect. And we should mention that when we talk about early introduction, we're really talking about that kind of 6 to 11-month-old age. So these are quite young infants. So we do have to worry about choking and about the texture of the foods and getting them into the diet that way.
Correct. Absolutely. So finding, again, thinning them out with breast milk or purees. Even taking, you can take the raw peanut or the nuts and get them ground down to something that is almost a butter. If you don't want to use the nut butters, you can do that at home, but you don't want anything chunky. They're just not ready for that.
And then how often do these foods need to be kept in the diet? So once we've introduced them, the kids are out tolerating them, how often do you recommend families keep them in the diet?
Well, that's going to go back to our whether or not this is a child at risk, where we're really thinking that we want to get this food in the diet and keep it in the diet because we really are trying to make sure that this child doesn't take that allergic pathway, right? We'd like them to go down this pathway. So for instance, we have a lot of information on peanut. We do want a peanut serving in their weekly, say 3 times a week. So you're, 2 grams 3 times a week. I mean, we are shooting for a fairly significant amount of, in this case, peanut, so that we're clear that we're not going to end up with an allergic kid. For those kids in the middle, and clearly the kids at the other end of the spectrum who we're really not that concerned about, integrating these foods, all of these allergic foods into the diet as they're ready and as it's appropriate, is mainly to make sure that we've got this very broad food palette for them, and that they can move, again, build on success and move forward from there.
And it's good for kids to have these different textures in their diet, to have
Absolutely.
different foods they can eat. So it's great to be able to have them in the diet. And those kids that have developed food allergies, what's the likelihood that they might outgrow their food? Now, I know it depends on the food, so maybe give some example foods.
So we know that with milk, egg, wheat, soy, some of these foods, we know that the kids have a high likelihood of being able to outgrow the food allergy as they develop. I don't know that we're very clear on the mechanism of that, but we know that it happens, right? For other foods, peanuts, tree nuts, fish, shellfish, they have a tendency to be more lifelong. There's a few, say 20% of kids that are peanut allergic that have outgrown their peanut allergy, but that's not the norm, right? So if a peanut, tree nut, fish, shellfish allergy takes hold, that has a tendency to be something that's going to be lifelong, especially if it's developed a little bit later in life. We do know that there's actually adults that will develop like a peanut or a tree nut or a fish or a shellfish allergy, and we just don't think that that's ever going to go away.
Right. And then we know that with egg and milk, getting that baked food into the diet can be both good for families because it's so much easier if that's in the diet, as well as it seems to be associated with outgrowing the allergy.
Absolutely. So we frequently will bring kids that we know are truly, truly allergic to straight milk and concentrated eggs, bring them into clinic and do a baked milk or baked egg challenge to try to get them on some amount of those proteins. Now you bake those proteins change because of the heat. They're not as allergenic. 70% of kids that are truly milk allergic, truly egg allergic, can tolerate those foods in the baked form. And if you can get them into the diet, to your point, it's a huge quality of life. It's cake. You know, we can get the kids to the point where they're tolerating birthday cake and pizza, and that's really what they want. There's some good supportive data that if you keep it in the diet long enough, you can actually get to a point where they can tolerate unheated milk and straight concentrated egg. And that's just an incredible goal, and you can get there from here. It takes a little bit longer, but again, a lot of the family's goals are birthday cake and pizza.
The things that are present at all parties. So we have a family who maybe the kid has had a food allergy and it looks like numbers wise it's coming down, or maybe they've been diagnosed with egg allergy and we want to try to get baked egg into the diet. Can you tell us a little bit about how food challenges work and walk us through discussing it with a family who's never been through it before?
So again, it can be very intimidating. We use oral food challenges in food allergy both for diagnosis, right? Because our testing, although we'd love it to be much better than it is, I'd love to be able to look at a profile and say, oh, look at you're ready for this. Let's add this at home, or let's give this body a little more time. You're not ready yet. Our testing is just not that good yet. So we ultimately do end up using oral food challenges both for diagnosis and the situation you're talking about, where we have someone we know they're allergic because they've either demonstrated symptoms previously at an exposure or they've had a food challenge or whatever, and we want to see if their body's ready to put this food in the diet. Either one of those situations involves an oral food challenge. What we do with an oral food challenge, we have a target goal, which is usually a serving. Sometimes we can adjust that to the patient's need, but let's say we're going to deal with a serving of, let's use baked milk as an example. What we'll do is talk the family through how to prepare muffins, cake, something that has baked milk in it, known quantity, and then have them bring that to clinic with them. We're going to start that challenge. Everybody has a little bit different approach, but everybody starts with a small amount, say 5% of your total target dose. And we have the child eat that in our presence, and then we keep an eye on them and wait 10-15 minutes, and we're looking for changes in skin, gut, and respiratory. With the little guys, you're looking for changes in disposition. Their personality is almost inevitably the first thing to go, but you're looking for changes after you've tried this small amount. If you get to 10-15 minutes in, everything is pretty much at baseline, then we'll go maybe to 10% of the total dose. Same thing. Feed that, let them digest, let them see if anything's happening, doing constant observations, and then, and proceed through over, say, an hour to get to the total dose of whatever your goal dose was. It's important to know during these oral food challenges that you have somebody in a situation where you can watch them constantly. I mean, I don't have somebody in the room, he looks pretty good. I think it looks good. You think it looks good? I think it looks pretty good. That's a little intimidating and it doesn't go well, but you need somebody aware. You need somebody, in the room, out of the room, in the room, out of the room. And I tell the family, if there's something that you're seeing that you think I need to see, just let me know and we'll pop in. So you need very good observation and supervision during food challenges so that if something happens, you're ready to respond, not react, that's the right word. When something happens, you're ready to respond. We pre-draw up epinephrine, antihistamine, steroids, everything that we think that we're going to need for a food challenge. We have that prepared. We have the luxury of our setup in clinic where we have a workroom where we leave all of that set up and ready, so I don't have to take it into the room and have it all sitting on the counter in front of the mom, in front of the kid, which is a little bit much. But some people don't have that luxury. I completely understand that. but knowing before you go in, before you feed that first dose of anything, you know exactly how you're going to treat if should anything happen. And sometimes it actually is helpful, especially with some of the adolescents, to say, here's what we're looking for. Here's the questions that I'm going to ask you. It's your body. You know your body. Tell me what's going on. Should something happen, I'm ready to respond. My job is to keep you safe. Your job is to communicate with me. We'll work on this together. So sometimes maybe having the meds there so that the family and the adolescent can see it is helpful. So you have to be aware of what your needs, what your family needs, what that patient needs. But always have your meds drawn up, have a plan in place. You know exactly how you're going to respond should something happen.
Yeah, I find it's important to spend some time with the kids beforehand to kind of figure out where they are. Some of them are
Exactly.
super excited, some of them are very anxious, and that just the thought of it already makes their stomach kind of hurt. Just because they've been told for so long this is something that could make you sick if you eat it, and wanting to really reassure them ahead of time.
And, you know, and meet them wherever they are. Now, we don't have that problem with the infants because they don't know, but you do need to know, is this a baby where I can engage, and this is a kid that's going to, you know, we kind of play a little peekaboo or something, and it's a very engaged child. What is my level of interaction with that baby? And then if I go into the room and that's changed, that is the first symptom or signal to me that I need to be paying a lot more attention because something's changing here. And again, that disposition in infants is something that goes south so quickly with a oral food challenge reaction. Could mean also that he's tired and or she needs a bottle and or she's just done with me. So that happens too. But you do have to engage and make sure that you've got a great baseline. The little bit older kids, even the toddlers, same thing. We kind of go in and be a little silly and stuff and see whether or not I can get somebody to kind of giggle or laugh. I walk into a room and that child who was fine and kind of, you know, making funny eyes at me 5 minutes ago is now sitting in mom's lap. Something's wrong. Something's wrong. And I need to investigate further. I need to keep an eye on things because things are changing. The dynamic is different. And that is your trigger to start looking for additional skin, gut, and respiratory. What are we seeing? What's coming? What's happening? Again, can a toddler just be done with us? Absolutely. But, you know, as soon as something happens, pay attention. The school-age kids, and again, with that anxiety, we do spend some time saying, you know, what's your job? What's my job? My job is to keep you safe. What's your job? You know, and if you can't tell Miss Kim, then if you want to tell Mom, that's fine. But I need you, it's your body. You know what's going on. You just need to tell us so that we can help you. I think somewhere in there they start being worried about, am I going to get a shot? And you have to be honest, right? That's not where we're going to start, ideally. My job is to keep you safe, but I need you to tell me what's going on. And so making sure that there's some trust there. The adolescents, something that we've learned the hard way is we never use the language pass fail. Nobody fails a food challenge. We use that language as shorthand as clinicians, and we need to stop because they hear. And oh my gosh, the worst food challenge I've ever done in my entire life was an adolescent male who was having a tree nut challenge, had never failed a thing in his life, and certainly wasn't going to start today. And his body was not ready for that tree nuts actually. And it went very, very badly. And some of it was that he had heard that failed language and he was not going to fail. The other thing that you have to be aware of, he's very smart kids. He knew that if he no longer had this tree nut allergy, he didn't have to carry that EpiPen. And people weren't going to harangue him about, do you have your Epi? Do you have a plan? He knew that. He's not dumb. And so we had set him up to fail. We really had set him up to fail, both by using that failed language and then, you know, having him be in a situation where the outcome of this food challenge determines whether or not you're going to run around with an epi auto injector on your way to college. And he denied symptoms, and it wasn't until I could actually visualize things that we knew, like, we're done. And by that point, that reaction had time to kind of develop, and it was harder to treat.
Yeah, absolutely. I've had the same experience where a kid has really, really wanted to pass and hasn't given you any indication of the early symptoms until they vomit or they start turning really red and start itching and they just can't control it anymore. And then you're behind.
You're coming at this from a bad place. The other piece to that is the kids that want to go to one of the, we live by the Naval Academy, and they want to go to the Naval Academy, and the military won't take them with a peanut allergy, and they know that. Again, that is a kid. That is a hard challenge to do, right? You have to be very, very honest in the front end, and boy, do you have to pay attention. The other thing that I have learned the hard way is that when one of the adolescents needs to go to the bathroom, not by yourself. We have a situation in our clinic where I can actually let them go into the bathroom and stand a parent right outside the door. And I say, listen, don't lock the door. I'm going to have mom or dad stand right here. No one's going to come in and embarrass you, but I can't have you in there with that door locked. I have had adolescents start reacting, not tell anybody, get up, get into the bathroom, lock that door because they want some privacy, which I understand, but now you have a locked door between you and a kid that's reacting, and I'm out here with the epi and you're in there and I can't get to you. So it is something that we've learned the hard way to be very clear about, and I tell them in the beginning, listen, bathroom's here, if you're going to use the restroom, I'm going to send an adult with you to stand guard at the door, but don't lock that door behind you.
The other thing that I've found can be really helpful is with those older kids who have a lot of seasonal allergies and may get some oral itching with the food, kind of warning them ahead of time that can be very much just pollen, doesn't mean you're reacting. We'll keep a close eye on it, but that's not going to be something we necessarily stop the challenge for, but it's something we want to keep a really close eye on. And I feel like that reassures them beforehand because they've already heard it. Oh no, this is my pollen allergy.
Right, and I think it's fair to say that if you get some mouth itching or some, that funny feeling in your mouth, tell me. It doesn't necessarily mean that this is a reaction. It doesn't necessarily mean that we need to stop. If you're telling me that I'm having these mouth symptoms and I want to stop, different conversation. I will listen to you, right? I will listen to you, but you do need to tell me so that we can figure out where we are. It's a very good point.
Absolutely. And then what if the kid just doesn't like the food? So it's not that they're reacting, but they're refusing it because they're like, oh, I hate the taste of that, which a lot of these kids don't have a taste for the food because they've been avoiding it. Do you have any tips or tricks to get that food in?
So we do ask families when they bring a food for a food challenge to bring multiple different kinds of the food, and the older kids where we're not worried about choking hazards and stuff, bring the powder, bring the nuts, bring the butters, and bring things to put them on. I have scraped so much cream off of Oreos and slapped a peanut butter mess in between two Oreo crackers. We frosting covers a lot of, you can put a lot of stuff in frosting and use that to get the food in. Chocolate covers most things quite well. And then some of the more savory things, I hesitate to do this with the younger kids only in that if you have somebody bring like a spaghetti sauce or a chili or something hearty that you're going to put, especially peanuts, tree nuts, fish into, it does cover the flavor, but a lot of food and they fill up and now you're done. And the other thing you do have to wonder is whether or not if it's going to slow down the absorption, and now maybe you need to spend a little more time in between doses and give the body a little more time to digest before you go on to the next dose because you put so much on call a matrix in there. But we've done everything but stand on our heads in the corners to get kids to eat things. And, I do try to talk with the mom beforehand and say, what flavors do they like? What do they hate? Do you think that the texture is going to work? He's eating some nut butter. Great. Bring that in. We can mix that in with these nut butters, and at least it's going to be a familiar texture, or it's, we're going to do a baked milk challenge in a little teeny weeny, and they haven't done any introduction of that texture yet. Okay, let's make a milk-free, egg-free, everything-free cake at home, and let's start that process at home and make sure that with some puree, they're ready to accept that texture, because I'd hate for you guys to come all the way down here, make this cake, we're all sitting here, and there's just no way to get the spoon past the lips of somebody who's like, I am not eating that. You know you're done when you walk into a room with a 2-year-old and they've got their arms crossed across their chest and their chin sticking out. You're done. We have, and that's going to happen, right? It is going to happen, and that child's not ready. We're going to have to work with them a little bit, give some ideas for introducing these things introducing this texture, not the food, but introducing the texture or the concept of a food allergy oral food challenge at home, and then reschedule and try this again where they're a little bit less anxious, a little more developed, a little less, no.
And then what if a kid gets through the challenge, they do great? What's the advice you give the families as they're leaving? So what's the instructions you give them?
So we try to make sure that when we're doing food challenges, it's going to be a food that they're going to integrate in the diet. It makes us crazy when we go through this whole process and you've come through and this kid's like, here's the food and we can add it at home, and the mom goes, oh, we're never going to eat that at home because we don't eat that at home. You're like, so what we'd like to happen is for the food to be integrated in the diet, right? The reason, not the only reason that we've done this food challenge, but a big part of why we've done this food challenge is to try to improve the diet, or at least decrease the amount of anxiety around eating. So we'd like the food to be integrated into the diet. Again, if it's a child, we're not worried about them developing a peanut allergy or an egg allergy. It's somebody who's ready to put this food in their diet. We're not going to say you have to eat, 2 grams 3 times a week, and we're not going to set those kinds of hard and fast rules. We do, so the day that you do the food challenge, you're done with that food for the day. You did a magnificent job. I'm so impressed with what you've been able to accomplish today. We're done for today. Tomorrow you can start. Tell me what you're excited to eat. Tell me what are you looking forward to eating, and maybe start the process that way. And then tell the family, put this in the diet. Make sure that there's, serving is a good place to start. If that makes you uncomfortable, you want to start with, a quarter or half a serving in the beginning. It's fine. A lot of times I get, should I feed it to him for breakfast and then let him go to school? And probably is fine if it's an area that's going to cause anxiety. Let's say, okay, for the first couple of weeks, why don't we do this in the afternoon when they come home for school, or do it with dinner or after dinner where they're home with you and you can keep an eye on things. If that's how you want to integrate this, that's absolutely fine. But we do want to get to a point where the food's part of the diet. That was why you went through this whole food challenge in the first place. We really would like that food to be part of the diet.
I've even had families put it in smoothies, like just to keep it in the diet. And so once a week, they put a little bit of that nut butter in the smoothie, and that's just enough to kind of keep it regularly in the diet. Or, make a bunch of muffins and keep them in the freezer and just defrost one at a time. So they're just getting that kind of every so often in the diet.
The freezer thing is brilliant. When we've had somebody that's come in and done like a baked milk or baked eggs challenge, and they've made this, entire cake, and we've fed this little tiny piece of it, I will say to the mom, listen, just take this, cut this up in your doses, freeze them individually, and then pull them out of the freezer as you need them. And I said, the next time you do this, perhaps maybe we can try something, maybe throw some cocoa powder in there and make it a little bit different next time, whatever. But making the doses that you're going to use and keeping them frozen is a really, really good idea, and cuts down on the fuss at home. It makes it easier for the family. The smoothie idea is brilliant. You could put a lot of stuff in a smoothie, especially if you throw ice in there and it's supposed to be chunky. Then if you end up with some chunky pieces of nut in there, it's a little less alarming.
And now if a child doesn't, we won't use the word fail, but they're not ready to eat this food, what are some possible scenarios that you've kind of encountered?
So when there's a reaction, I think you did such a great job. You knew your body. You were you were able to communicate that with us. We were able to treat this, even if it's a time where we've given some epinephrine. After we're all done, you were unbelievably brave. See how quickly this medicine worked for you and kept you safe. I don't want you to be afraid of this moving forward. This puts you in control. These kinds of conversations, putting it in whatever context that either the family or the child is ready for. So start out with, you did such a magnificent job today. We asked so much of you, and you were able to do this, and I am so very, very proud of you and so impressed how brave you've been today. So that part, we start. And then there's disappointment. There's going to be either you're dealing with a family who's looking at a teeny weeny who doesn't know that they didn't do well with the food challenge, but the parent does, and we need to make sure that we give them as much support as possible. What this means is that we're not going to put this food in the diet. The body's not ready for it yet. That doesn't mean it's never going to be ready. Here's how you avoid this food. Here's what we do. We're going to take, milk's not going to go into the diet. We need to start talking about other ways to get fat and vitamin D in the diet. Whatever the issue is with the food, however important that food is into that food protein is in the diet, we want to make sure that that the family has, how do I avoid this? Making sure that they understand this isn't necessarily forever unless we think that it is forever. And if you're going to pull those foods out of the diet or not add them into the diet, we do need to be aware of the fact that this sets them up for nutritional deficits, and we have to anticipate that and give them guidance as to how to replace those calories, the vitamin D, the fats, and the things like that. It's not a great teaching time after a food challenge, especially if you've had a good rocking reaction and you've done some epinephrine and everybody's they're sort of done. And it's so trying to be supportive and make sure that they don't leave devastated is maybe as far as you're going to get to that first visit, but you're going to need follow-up after the fact, or at least get them resources so that when they're ready, they can access more information. They might not be ready at the end of that visit, and understandably, but we do need to make sure that they know, and the next step is, right? It's never here's the end, done, and the next step is.
I do find that sometimes it's the first time a kid either remembers having epinephrine, they may have had it when they were very young, or their first reaction wasn't that bad, so they didn't need epinephrine. And so just having them experience how much better they feel so quickly, that can be
So
actually really eye-opening for them.
We know that there's research out there that says even if somebody has, say, failed challenge, it increases quality of life both for the kid and for the family. And I think that that's exactly what you're saying, which is it gives them some control. So, okay, that wasn't so bad. So often we hear that wasn't so bad, or oh my gosh, that worked so fast. And we, talk through this is, as often as possible. I try to when we're doing if we have to treat with epinephrine, I'm trying to teach through that. Here's the hold I'm going to use. See how I'm putting him. See where, I'm holding her. She's right here with you. This is what I'm going to do. Everybody's safe. So try to do the teaching all the way through and make this be as normalized as it possibly can be. And then afterwards, so see your heart rate, put your hand right here so you can feel her heart rate. That's exactly what we want to happen. Yes, she's losing the face color, and she might even lose her lip color. Don't they look ghastly? It's fine. She's going to pink up in a few minutes. This is exactly what we expect. This is exactly what we want to happen. Now, if this had happened at home, at this point you'd be calling 911. And again, we don't have you call 911 because you've given a dangerous drug. We had you call 911 because we want you to be observed for another 4 hours after that. So you're doing your teaching is constant as you're going through the process, so the family understands where they plug in, how to manage this at home. What reaction, what symptoms did we see that prompted the epinephrine use? See how quickly that resolves. So it's a constant teaching, so that they understand what's going on, right? And they feel like it empowers them to do it at home.
Even just appreciating which dose they got to. So sometimes if you've gotten through most of a challenge before a reaction happens, reassuring families, look, if you had a very small accidental exposure, it's unlikely to cause much. Look how much you were able to eat before the reaction happened. I think can be really reassuring for families.
And you're completely right, which is, this is, as you say, this is not likely, a small exposure is not likely to cause this major reaction, which is good to know. Or if you're at the other end of the situation and a small reaction did cause a major reaction, now we know, right? Now we know that. And now what are we going to do with that information? To keep you safe, here's my suggestion. If you even think that you've been exposed, that's a different treatment plan than somebody that we know can tolerate, a gram of something before they have a reaction, compared to somebody who just, the first 5% of whatever it was really threw them over the edge. Different teaching plan.
Yeah. And sometimes I know a lot of us, if we get to a kid who gets through most of a challenge before their symptoms, and maybe their symptoms were actually mild, we talk to the family. This could be a family that wants to start introducing a small amount of food into the diet consistently. And with the right instructions and coaching, it can be a way to get a little bit of food in the diet. So actually, even that can be a failed challenge, but actually a success overall.
It can be life-changing. It can be life-changing. And, again, in our clinic, we choose to do that as well. Some people are not as comfortable with that. But, if you can do that and say, okay, listen, you're not ready for a full serving of this, well, we certainly can start down here at, 300 milligrams or 500 milligrams. And this is what that looks like, making sure that they understand what the retail food equivalent of 500 milligrams or, that's how we have a tendency to think of these foods, but making sure that we translate that into grocery store language is very, very helpful for people.
Absolutely. Now, is there any advice or reassurance for food allergy families that you'd like to end with that maybe you found helpful over the years?
I would say one of the things that I have learned over the years working with all age groups, but certainly when we get to the adolescent age, I say to my families, your child has been advocating for himself, has been learning knows their body. She knows her body. And you've already instilled this in them. They're coming into adolescence, and I always say there's sex, drugs, and rock and roll coming. You've already started that very difficult conversation about making good choices, healthy choices for your body, knowing your body, advocating for yourself. You're just so far ahead of some of your peers because you've already started this. You've already given them some context to make decent decisions, grown-up decisions, mature decisions, but it's important stuff. And you're ahead of the game. You're ahead of the game. And even with the younger kids, she already understands that it's important to be healthy. She already understands the importance of advocating for herself. He already gets that he has choices and he should make smart choices. So that process that you're using to teach your child and keep your child safe applies to not just their food allergy, it applies to their life.
Yeah. So it's actually a great way to connect with your kid and really give them advice that's going to serve them well.
Agreed.
Okay. Well, thank you so much for taking the time to be with us today. I think this will be a very helpful information for families, for people with food allergies, as well as all of us that take care of them.
Thank you for having me. I truly appreciate it.
We hope you enjoyed listening to today's episode. As a reminder, this podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence-based information. Any questions pertaining to one's own health or one's own food challenge should always be discussed with their personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board-certified allergists in your area. Use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at the Academy website. Please visit quadai.org for show notes and any pertinent links from today's conversation. If you liked the show, please take a moment to subscribe and review our podcast through whatever podcast service you use so you can receive new episodes in the future. Thank you again for listening.